Senator Di Natale in point one.
Thank you. I suppose I can't help perhaps just taking the bait on that last response, and I think that was a slight, well, an oversimplification of the choices that that confront us when we're determining prices. You're ignoring the fact that paying over and above the cost of drugs in some countries actually deprives us of the choice of listing other drugs. That's one thing that I think it's not quite as simple as we're providing choice of generics. I mean, really, does it matter if we've got 5 different generics on the market? It's not, that choice isn't particularly relevant.
No, but that choice and the competition between those generics actually drives the price down.
Well,
and that's the important thing to understand.
Look, I'm not saying there's the perfect answer, but there are other mechanisms of driving, there are other ways to drive the price down.
Well, Senator, this is actually a conversation that's worth having, because you can go a tender approach,
Yes.
but let me tell you that what you do is actually restrict the supply alternatives. I have multiple conversations with my colleagues in overseas countries at the various fora that I attend about medicine supply and shortage. And this is as a consequence of things which...
But they list the drugs that we don't list.
No, they don't actually.
Oh, well, no, that's not true. In some cases, they can list drugs that we don't. And
but they might list drugs which don't have a cost benefit.
I'm not saying there's a right or wrong answer, but I just think it's a bit more complicated than the scenario you painted. And if you're paying a lot less for your drugs, you can actually provide more drugs. And so the question of choice is not necessarily...
I actually really don't agree with that, Senator.
Yeah,
I really don't agree with that.
I'm sure you don't. I'm sure you don't.
We pay below the OECD average as a nation on the drug bill.
Because it's skewed, because some countries pay way above what they should be paying for their drugs.
No, in some of those countries they actually pay on individual products lower, but their approach to listing is not evidence-based. Our approach is evidence-based. We do a cost-benefit test that is the toughest, and I can say this absolutely confidently, it's the toughest in the world.
Yes.
We have 94 medicines on our PBS than in New Zealand. So even though the Grattan Institute report lists a very small selection of medicines, the truth of the matter is you look at their total drug bill, it's no better, in fact it's more, and we have 94 more medicines than in New Zealand.
Yes,
then you go to Canada where they tender in some respects, and let me tell you they have had shortages.
Yes. Yes.
Anyhow, I think it's very healthy to have a robust discussion about all this.
Yes.
Thank you, Senator.
So
look, I'm not actually arguing for any particular one. I'm just saying it's
much.
actually there are some very difficult choices, and there's a tension in this, and I think it's worth talking about some of those issues. But can I just talk about the...
Oh, sorry, Senator. Before Senator Heffernan goes, I'm sorry. I have a little bit of good news for you. You asked a question. I'm so sorry, Senator Di Natale. You asked a question about the median for unplanned absences.
Ah, yes.
So, Doha, including the TGR, OGTR and NICNAS, sick leave median absence days taken per FTE for 2011-12 is 6.8 days.
Wow. DAF is 15.
I thought you'd like that. The department's average number of sick leave days absence per FTE was 10.7 days in 11-12, and this is trending down with the current rolling average of 12 months being 9.31 days, but median, I thought you'd like that. Yep. The APS average, this is a small amount of boasting. The APS median 212 State of the Service report is 8.5. There you go.
Just thought I'd keep them on the ball.
Yeah, well, we're on the ball.
God bless
Sorry,
you.
Senator Di
That's
Natale.
okay. So I just want to sort of talk about some general numbers in terms of the PBS. So the spending on the PBS over the forward estimates is going to be $2.8 billion lower than what was estimated in the 12-13 federal budget. Is that right? I've got...
Excluding new listings.
Yes.
Yes. Yes.
So we're looking at a $2.8 billion. I think it was 43.3 in 12-13 and 40.5 2015-16.
And the risk of going back over the ground we've just covered, Senator, this is a result of price disclosure.
Yes, yes. And I'm certainly not arguing against price disclosure. Some people might argue it needs to happen a little more rapidly.
Oh, that's a conversation we can
Sure,
have. I agree.
sure. I suppose the question for me is we keep hearing about the PBS being out of control and unsustainable and so on.
You're not from me.
No, well, we do hear about it from various people, and I've heard various ministers in the past describe it in that way. And I think there's always, the goalposts seem to be shifting a bit as well. So, I mean, given that we've got a $2.8 billion saving over the or an estimate that's lower than what was projected in 12-13. But I think it was in Feb 2010 when Minister Roxon at the time said that the PBS reforms that actually provided some savings were going to be outweighed by higher growth in PBS costs, which are actually at that time were expected to reach $13 billion in 2018. And I think that sort of gave rise to this notion that it was unsustainable.
Oh, no, Senator, can I just make a comment about that?
Yes.
I started working on the PBS when I went to the Department of Finance in 1988 for
Yes.
my sins. And that was before the PBS budget had hit $1 billion. Assorted ministers at that time were bandying around the words unsustainable, even in those days. So it is not fair to say that that word has not been in common currency for as long as I can remember.
I agree. No, I'm not trying to...
So I mean, I do.
I don't want to shoot it home just to the minister,
Okay,
but I think
thank
that I think was part of that whole narrative about things being unsustainable. But then we've got a situation where, you know, this year's federal budget papers talk about the projected spend with growth in PBS expenditure of 4.9% from 2013-14 to 2016-17, basically saying that the expectation is that increased transparency, that is the disclosure, will help to stabilise growth in the short to medium term. But that actually comes to a number of, you know, if you extrapolate that 4.9% figure of $13 billion, you know, in 2017, 2018. So on one hand, we've got someone saying, well, we're stabilising growth at 13 billion, and only a couple of years earlier we're saying 13 billion, the whole thing's spiralling out of control. I mean, there's sort of mixed messages here, aren't there?
Well, you're asking for a comment, I guess, Senator. And look, when we started on the price disclosure world, and I mean, we've already had that exchange about price disclosure. I very strongly believe the price disclosure is the right policy. I really do.
Yep.
And I mean, one of the things about embarking on a series of reforms in what is an incredibly complex program, and something, I mean, I don't know whether you know this, the PBS is the second longest serving social policy instrument in the Western world after the NHS in the health space.
Oh, look.
And
Hey,
so
I love the PBS.
Yeah, but I think it's important to kind of put it in that kind of historical
sure.
narrative. And what we've done over the many years that we've been running the PBS is we've continued to manage it, drive down growth and expenditure. And when we started on the PBS reform route, which, to be fair, goes backwards beyond this government, so we've been on this route for a while. There is always a bit of a punt, an estimate, an informed, sorry, Hansard, thumb waving in the air about trying to find a spot. There's an informed process of modelling, guesstimating what the answer will be. And so we as a department will have a particular view. Other people will have different views. And you know as well as I do that there are a lot of people who want to see the drug budget as being very difficult. And if you look at historical growth in the drug budget, it was one of the fastest, if not the fastest growing element of government expenditure for a good number of years. So I understand why people regard this as being something of great concern and something to be watched with interest. Now, we were very confident about the reforms on price disclosure. It would drive down the drug budget, and it will basically give us what we call headroom for the listing of those high, innovative, new medicines, and the kind of data I just quoted you about New Zealand, I think, is an example of that. And so I understand why, for a period, people have continued to talk about spiralling out of control, etc. My personal view has always been that these reforms were going to drive a much more sustainable approach, which would give us a capacity to keep listing. So I think the fact language has survived for a while is a perfectly understandable function of historical experience. But what we're seeing now is the dividend from these reforms.
Yes, I accept that. I suppose the point I'm making is simply that, 1 year, the $13 billion figure is things are out of control, and then a year or two later, $13 billion, we've actually stabilised costs. And it seems that...
Well, you don't want to overclaim, do you? I mean, I understand why these... We all understand why these things happen.
Let's perhaps just look at a few specific issues, and I'm particularly interested in the MOU and some specific clauses within the MOU and the Access to Medicines Working Group. There's the Data Working Group, which is a subgroup of the Access to Medicines Working Group. What's the role of that group?
The Data Working Group is bringing together the department and the industry representatives in Medicines Australia to come to some common understandings about drivers of growth in the PBS. Yep. So the incidence of chronic disease, the ageing population, the changes in the patent and off-patent dynamics within the PBS. It's about trying to have a common agreement about what is driving the PBS and help us to have a common understanding about what we're planning for in the future, looking at the types of also developments that are coming in the pipelines of the pharmaceutical space as well too.
And the working group, along with the department, are required to produce reports, regular reports?
We're required to produce a report, Senator, yes, which the Minister published, I think it was 2 weeks ago, off the top of my head, maybe a week ago.
The requirements to produce 6 monthly reports, is that correct?
On the Data Working Group?
Yes.
The Data Working Group
Perhaps I can... It's expected to monitor and to report on PBS expenditure trends and growth drivers on a half-yearly basis.
Yes, so that is the Access to Medicines Working Group is the group that brings together the departments and Medicines Australia, and there's a subgroup of that which is the Data Working Group, and it provides regular updates to the Access to Medicines Working Group on how that is going. What has then been produced is a full report based on that initial work, and that's been published by the Minister. That report, of course, is a point in time, and we continue to update and model accordingly.
But isn't the Data Working Group expected to produce 6 monthly reports? And there's only been 2, as far as I can tell, from the 1st of January 2011 up until the present. And by my reckoning, there should have been 4.
It's not a requirement to actually publish on the department's website the 6 monthly reports. It's about reporting back to this Access to Medicines Working Group, and then when the reports are at a sufficient point in time and have sufficient information, such as the one that we've actually published on the website in the last couple of weeks, that's made publicly available for everyone to have a look at.
I suppose I'm just using the words that are in the agreement where it says it's expected to monitor and to report on PBS expenditure trends and growth drivers on a half-yearly basis.
It does, Senator, to the Access to Medicines Working Group,
so
but an annual report
doesn't have to be a written report, it just needs to be, a verbal report?
Sometimes that's a verbal and sometimes it's a draft report that's given every 6 months. A finalised report based on that work has been published on the internet, which is the first report that's been made available.
Okay, all right. I suppose looking at the report itself, the section states that the analysis confirms that even after including the impact of net new listings, the impact of changing prices of existing medicines continues to have a significant dampening effect on PBS expenditure growth. I mean, that to me is saying that the growth is controlled. I mean, as we said earlier, there's some confidence that
I think, as the Secretary already referred to earlier, yes, Senator, the growth has gone from being predicted to be about 7% in the long term to 4 to 5%, and that's a reflection of that. That's also been reflected in the variation to the forward estimates that we've seen a couple of rounds of the price disclosure now, and that has shown that drugs are taking multiple price reductions, and the forward estimates have been reflected to show that.
And the report also says that the F1 medicines or patented
Well, not
medicine,
completely,
but it's
medicines
the
without direct competition.
yes. Okay. Well, yes. Continue to contribute a significant minority of PBS expenditure growth. That's sort of suggests that new innovative medicines listed on the PBS as F1 medicines aren't actually drivers of growth in the PBS.
Well,
is that a fair call?
They are drivers of growth.
But not the major drivers.
Can I say it is a bit of a, I hate to say 50-50 split, but it is a partial thing. So, script volume grows by 3 to 4% a year. So going from 188 million scripts to 199 million scripts adds cost to the PBS. But then if I look at the last 2 financial years, in 2011-12, the government approved $545.6 million worth of new listings, and to date in 2011-12-13, a further $692 million. That's almost $1.2 billion that's been added to the forward estimates of the PBS. So there is, both of them are actually contributing to that. As the Secretary was referring to earlier, price disclosure is helping to balance and offset some of that.
Okay. Can I turn to the diabetes review? Now, the review looks at medicines. Am I right in saying it also looks at, it's looking at implantable devices?
The insulin pumps?
Yes.
Yes, Senator.
And glucose strips as well?
Yes, Senator.
Why is the PBAC looking at implantable devices?
So, Senator, the PBAC is looking at the use of diabetes medications, particularly in the type 2 space. And in particular, that of course led to the fact that glucose test indicators are used quite prevalently in type 2 diabetes, and that is something that is also listed on the PBS, and they asked for that to be looked at as well. The insulin pumps was something that was drawn to the PBAC's attention because they had noticed that as they were looking at the different uses of insulin, we also had a program for the insulin pumps and how that was being used. The flow-on effects, the more efficient potential administration of insulin and monitoring was something that also they had decided to look at as well too.
But
now it's not, can I just clarify, it's not specifically the PBAC that's looking at that.
Yep.
It's a post-market review. The drugs and the glucose test strips are being examined because PBAC had specifically asked for that to be looked at in the broader context of diabetes. That had been identified as an issue, and the reference group is actually looking at that material. That doesn't necessarily go back to PBAC.
So tell me how post-market review works then, when you say the PBAC aren't looking.
So post-market reviews can be initiated as a result of a recommendation from the PBAC to government to look at a particular issue. Equally, it can be something that is identified by the department or by the minister that is requested to be considered. Likewise, we looked at the use of high-potency statins as a result of a request from the Senate to actually consider those. So they can come from a number of different areas.
And who does the review?
So the review is coordinated and managed by the department. We have an independent reference group that includes clinicians, consumers, experts in the particular area. So the diabetes one has representatives from dietitians, it has endocrinologists, it has paediatricians, a number of other people on it in that area, diabetes educators. Then we also have the fact that we can use independent evaluators or consultants to actually do the research and analysis work of the clinical evidence that's already presented and available in the public domain. We then invite submissions from the public, which includes inviting submissions from representative groups, from sponsors of particular drugs or particular glucose test strips, or others that feel that they may wish to make a submission. Those are then summarised and put back to the reference group for consideration as well. then it can be a choice if it's something that has been recommended by the PBAC and has impact on matters that are on the PBS, that will go back to the PBAC for consideration. Alternatively, if it's not something that's related to the PBS, then it goes to the Minister for consideration.
Okay, so in the case of the diabetes review, we've got glucose, we've got medicines, we've got implantable devices. Just so I get an understanding of how this works, the review's commissioned. The medicines part of that review, is that done by the PBAC or is it just sent back to the PBAC?
The evaluation is done by external evaluators for us.
Yes.
It goes to the reference group for their input and advice on the report.
Yes.
Then, depending on that report, that then goes back into
Right.
PBAC because it was specifically a recommendation
Yes.
by PBAC.
Yes, and of course if there are changes in prices there, it's going to flow on to other, it could potentially impact on other medicines.
It could potentially.
Perhaps I'll go to some of those medicines. But has there been an increase in the number of reviews done post-market?
I don't think you could say there's been an increase. It's a new program, Senator. We've only
When did it start?
It started in the 2012 budget.
2012. So this process has only been going since 2012. And how many reviews have been done?
We've completed the anti-dementia drug review for Alzheimer's disease. We had the anticoagulations in atrial fibrillation, which has been completed.
Yes, of course. Sorry, of course. Yes, I was trying to work out whether that was part of it. Yes,
That's
thank
okay.
you.
We currently have the review on medicines used to treat asthma in children, and we have the medicine and products used to manage diabetes.
So the trigger for the review in each of those cases, can you tell me how they were, who commissioned the review?
Certainly.
Because, I mean, it strikes me as strange that you've got the for example, the anticoagulant review. I don't want to go over the old ground here, but, I mean, there was a recommendation for listing and the review came after the recommendation. I'm not sure whether that was a request from government.
The review of the anticoagulations was based on a PBAC recommendation that when they recommended the potential listing of dabigatran, they also noted in their recommendation to government that there were significant opportunity costs with respect to that listing, that the profile of the clinical data that was used in the trial was different to the average age population in Australia, and that when that was translated into the Australian population, there was some uncertainty.
But they recommended it for listing.
Yes, but with those caveats.
But it's recommended for listing. Like, I mean, that seems like a bizarre situation where, on one hand, they're saying this should be funded under the PBS, and then are they suggesting that their own work's called into question? I don't understand that. I mean, they're saying it's a cost-effective medication, it should be listed, and then somehow a review happens of the drug, which subsequently results in the listing not proceeding.
No, the government accepted the advice of PBAC and decided to have a review with respect to those concerns that PBAC had noted.
Right, and not list the drug. Yeah.
Well, not to not list, but to basically ensure that the full range of material, including the review information, was made available.
Sorry, can I just on that?
Yes.
What's the next step there? Ms McNeil.
So the review report was concluded last year. The government then asked, specifically the Minister asked PBAC to consider the report after she had seen the report. They then said that they were of a mind to rescind their previous decision and asked for new submissions from all sponsors of the novel oral anticoagulants, so rivaroxaban, dabigatran and apixaban. Those were all considered at the March PBAC 2013. They were all received a positive recommendation.
But can you see how this, I mean, we're talking about how wonderful the PBS is, and we love the idea that the PBAC is an independent process, arm's length from government. We trust the people on the PBAC. PBAC A drug company puts a drug to the through the process. It's difficult, a difficult process, and some might say becoming more difficult, but it's a difficult process. The PBAC then make a recommendation and say, yep, ticked all the boxes, cost effective, list it. And the government comes in and says, actually, hang on, we're going to review this. And the review happens, the drug's not listed. And
So I think actually it's important to make a bit of a distinction here, Senator. So the PBAC deals with things as they come through the door. That's what they're tasked to do.
mm-hmm.
And they deal with those things relative to existing things, which is completely appropriate, and on a
Yes.
cost-benefit basis. Now, it's open to the government to say, interesting, big class of things, might think it's worth having a bit of a look at in a broader context. So instead of...
Very different approach to what's happened in the past.
No, actually, that's not true. We have done this before.
Oh, once or twice?
Well, nonetheless, when you talk...
but
when you talk...
This is a substantial shift in the way drugs are listed.
I don't agree, actually. I mean...
Well, you've just outlined dementia, anticoagulants, asthma, diabetes, in the space of, a year and a half? I mean, huge classes of drugs, substances which have been shown to be cost effective. The whole point of the PBAC so governments can't mess with it.
So
and now we're seeing a situation where...
I actually don't agree with that, Senator. I mean, governments can legitimately ask questions and ask for a broader look. It doesn't change the judgment of the PBAC. It says we're now authorising you to go away and have a think about this from this broader perspective. And if you think about it, it's not unlike decisions that have been made by government to have, and I almost loathe to say this because everyone reading this transcript will go, therapeutic groups. There are times when government says, we just want to think about this from a broader perspective. And this is not the first time we've done these. But particularly when you're looking at blockbusters, big drugs that come through, it is a fair question to say, in the context of other things in this class, what do we think about this? And they still say, come back and give us your advice, but go away and have a look at this. And that's what's happened in a couple of cases. I think it's actually quite legitimate. And particularly when you're talking about now a much bigger group of medicines, some of which are very old technology, some of which are completely legitimate still, and some of which are very bright, new, flashy and shiny. So you're saying, all right, what is the relativity amongst these? What does that tell you?
Sure.
And can I also...
I understand that, but I'm not suggesting it's not legitimate because, government can do what it likes. The question is, does it represent a fundamental shift in the way that PBAC has assessed drugs and the way they found themselves on the PBS?
Yeah.
It's very hard to argue that a process that has resulted in systematic reviews of 4 classes of drugs, huge drugs, for the first time we're saying we're going to put another hurdle post the listing of or the recommendation for listing of a drug. So even if you spend, I don't usually go into bat for pharmaceutical companies, but you spend a lot of money and time.
I'll quote you on that, Senator.
I'm happy to be quoted on it. And now there's this new sort of hurdle that's been put in front of.
And you know what I would characterise this as? We talked earlier about the PBS being the second longest public health instrument in the world. If you look at what happened with the PBS right back all those years ago and how it went about its business, it looks completely different to how it looks today. And we have, consistent with advents in pharmaceutical breakthroughs, technologies, everything else. And if you think about the world we're in today in terms of medicines, we're right now into the world of personalised medicine. Huge technological breakthroughs. It is completely appropriate that we refine our approach. Now, I take your point, which is you go through a process and you think that's the big tick. And we have a series of agreements with the industry about how we'll operate, but this is a legitimate question to ask. And it is fair to say that there is an MOU between the industry and government about how these things will work, and that is genuinely entered into and genuinely observed. But I do think it's also appropriate, and this is why we continue to talk to industry. I talk to industry a lot, as do my officers. it is appropriate to understand, much like the PBS reform strategies that have gone through Parliament, we need to keep modernising the structures. We need to keep the system that means we've got 94 medicines more than New Zealand.
But my job is to actually make sure that, I mean, modernisation doesn't become a euphemism for trying to look for savings through the PBS when a government's trying to save a few bucks from somewhere. And I'm not suggesting this is the case, and we're talking generally. I mean, your view of what is, an evolution of the PBS, may actually amount to a chipping away of what is a very thorough, independent, and globally, recognised process.
Yes, and let me make a suggestion to you, Senator. If that process had led to an outcome that was no different to the first outcome, I don't think government would have had a problem with that. It was a test. It wasn't an insurmountable hurdle. And
It was pretty close.
Oh, I don't agree with you.
Pretty close.
I actually genuinely don't agree with you. And if we go back to your question earlier in relation to the tendering version and the pricing, I mean, my view is we're better to have these high value tests placed on what we actually list and the price we pay than going the lowest common denominator approach, because it means we continue to test robustness, science, value for money, and that's what we're doing.
Through the PBAC process.
Correct. And remembering...
That's the whole point of the PBAC
correct.
Process.
That is correct.
Right, and,
So
and what
you
I'm
and I
suggesting to you is we already do that.
And therefore
and then we put another hurdle in front of it.
No, we ask them to do more work for us in pursuit of our objectives.
Yeah, but haven't they then done it? I mean, the company that's, for example, with the atrial
Fibrillation Centre.
Yes. I mean, I understood that those companies have now done everything that they can, even in the second round. So what happens now? They just sit and wait for the government to list. Is that the next practical step? Isn't that the situation?
Yeah, so I mean, we've got
done
a process.
that. We've gone through two, the sort of hurdles
and let's be clear. I mean, Ms McNeil's busily writing me notes here saying that the reviews are based on dusk, that, the whole approach is based on dusk reviews. That's absolutely true. I mean,
Sorry?
The Drug Utilisation Subcommittee of the PBAC, Senator, and what it does is... Dusk. It's not just that when you list...
It's an acronym, I'm sure.
It is.
Totally.
It is. When a drug is recommended by PBAC and subsequently listed, it is an automatic thing to undertake, which is 12 months thereafter. The Drug Utilisation Subcommittee checks that what the company foreshadowed would be the expected utilisation and use of that drug is happening.
Yeah.
So that's why we've had reviews such as the biological DMARDs, where the Dusk found that there was a 25% overutilisation than was expected. The reason we're undertaking
The
biological disease modifying anti-rheumatic drugs.
Yes.
So that was
known
one.
as DMARDs.
But what about drugs that aren't listed? Are we talking about reviews on drugs that haven't even been listed?
Yeah.
But you've also asked me about the asthma review, Senator.
drugs that are listed.
Yes, but hang on, you're talking about...
Yeah, this hasn't
a
been
red
listed
herring.
yet.
It's
This
a red
hasn't been
herring.
listed yet.
I accept that you want to have a look and
Yeah,
the evidence has
accept
been
that.
put forward and you want to test the evidence after the drug's listed. Yeah, fair enough, I've got no problem with that. But you can't make that an argument for a drug that hasn't even been listed yet.
But there are drugs in that class that are listed.
Well, Pradaxa wasn't.
But warfarin was,
Warfarin
Senator.
was.
Oh, yeah, okay, so that's the test now. The test now is every drug that gets listed, we're going to have a post-market review against an existing agent and see if we can do something about the existing agent so we don't have to list the innovative drug.
No, it's not whether we don't have to list. Let's be really clear about that. The issue...
So we have to raise the hurdle.
No, it's not even raise the hurdle. We need to be very clear, for example, in the case of warfarin, and I can actually, well, I won't actually tell you who the person is because he's very well known, and therefore I probably can't tell you the details, but I know for a fact that medically, that there are some people who get moved on to these new products. In fact, if they use the existing product appropriately, and in fact the particular person who's a very well-known individual,
It's the whole point. They're not.
They're not what?
I mean, if they use the... Okay, so what you're saying
Just
there
can't
is
use warfarin.
we're going to compare... What we're going to do is we're going to compare the innovative drug against some hypothetical scenario.
No, this is the point.
Not a real-world scenario.
No, this is exactly the point. There are circumstances where an existing drug, if it was used optimally, would act, yes, and that comes down to then clinical care and utilisation by the patient. So we can actually, and this is precisely the circumstance I'm talking about. So I actually had somebody at a social function, elderly man, not going any further than that, tell me a story without knowing any of this, which is precisely about one of these products in exactly this circumstance, had been put on one of these novel products, courtesy of the manufacturer, thank you very much, when this was not actually, as it turned out, optimal, has now gone back to the original product, is using it appropriately. And this is merely the test we're applying. It does not mean, on the contrary,
I don't know
that
that anecdote changes a thing.
Well, actually,
what does a cheesy anecdote do when you're talking about...
Well, forget cheesy anecdotes. There is a question here about what is the comparator.
I agree, absolutely.
And the comparator...
is what's happening in the real world.
No, let's be clear. A comparator about a product which is used properly as against a product which is used sloppily.
Okay, so the next time an antibiotic gets listed comes up for listing, we're going to go back and talk about non-compliance with antibiotics, and we're not going to list it because we know that most people don't complete their course. You're not going to get listed because we know we can do better across a whole range of other antibiotics to improve compliance. That's just a nonsense.
Well, maybe you have a lesser opinion than I do of the ability of the clinical community and indeed patients to improve those things. It's a question, but Senator, it's a question that's worth asking. And that's the point. The point here is, should we ask that question? And it might be right. Take an antibiotic. It might be the question, and we all know the issues around antibiotics. We don't need to go there. It might well be the case that you ask the question and, no, you're not going to be able to do anything about compliance, you're not going to be able to do anything about that. That's the right answer. But why can't we ask the question? And that's all we're doing.
Well, if you're going to ask that question, you need to be very honest about what's going on, and what's going on in that scenario you've just painted is a radical departure from existing practice where drugs are assessed against a comparator in the real world. This is how this drug's being used. You're going to compare your new drug against what's happening. We're not going to say compare it. If it stacks up, we're going to go back to this other drug and we're going to have some sort of campaign to try and change the way this drug's used, and then we might come back to you and say, right, have another go. I mean, that's the...
But go back to the argument.
Dr. Ms Holton,
You can call me doctor as well if you like.
Can we just use the warfarin? Can we just stay on this particular drug? And in relation to the warfarin, what are you now expecting needs to happen in the usage of warfarin before we can consider these three other drugs? That's the point that I'm trying to understand from what you're practically saying, Ms McNeil. Can you just explain that to me?
So the PBS, when they originally recommended dabigatran, had found that one of the reasons dabigatran had a cost effectiveness or clinical advantage was because warfarin was used suboptimally in the Australian population in comparison to overseas where there was much higher compliance.
Okay. And that was very clear.
So the review looked at the use of novel oral anticoagulants in the Australian population and the potential suboptimal use of warfarin in the Australian community, and looked to see, could you improve compliance and use of warfarin in the Australian community, and if you did, would that have a different outcome? Would that be a better outcome? So that's when there was consultations and looking in the pathology space about INR testing, through the apps, there'd been trials in Tasmania through pharmacies as to whether they could do those things. So the review was concluded and it made a number of recommendations, and it has looked at the fact about whether you can have point of care testing in pharmacies, whether you can change the way general practitioners, the optimal use of Medicare locals, and so those policy ideas were put forward.
So we're going to wait for rollout through Medicare locals to listen through?
No, Senator.
No.
They were recommendations for saying there are a number of different ways that you could try and improve compliance, and based on the use of warfarin in the Australian community and based on the primary care options within Australia, this is how you could try and improve warfarin compliance.
And in the interim, these 3 drugs just sit out there potentially for a year, 2 years, 3 years, while we work out how we can better utilise and better get people to use warfarin. Is that what you're saying to me?
That isn't what I'm saying, Senator, or I've said what the outcomes of the improvement of the recommendations were for warfarin use.
Ms McNeil, how long is this process?
In the meantime, Senator, the PBAC has considered the revised submissions from those 3 drugs, and they have actually published the outcome.
And it is proceeding.
Which is that rivaroxaban, dabigatran and apixaban were all recommended by the PBAC. However, dabigatran and apixaban were recommended on a cost minimisation basis to rivaroxaban.
All right, so now we're in the position where it's now we have to wait a decision of government basically to list. Is that where we're at?
Yes, but that's no different to any other circumstance, and all the usual rules about the time frames, etc., around those things apply.
All right. Okay. So, sorry, I just wanted to understand that.
That's okay. I suppose all I'm suggesting to you is sometimes these changes are presented in a way that presents them as minor changes. Now, there may well be an argument, as you've suggested, that in some cases we, particularly with blockbuster drugs, we need to look at whether this is an appropriate approach. But we've got to call it for what it is. I mean, it's a very significant change. I mean, you talked about refining and, you know, the PBS. This is a pretty significant departure from what has been regarded as the way the PBS has operated up until this point. And, you know, after seeing this play out over the past couple of years, I've come to the view that it is a significant departure. What the policy debate needs to be around whether it's an appropriate response. And we haven't had that debate yet. We've essentially been presented with some information that says, these reviews are minor. They're all about improving patient safety through better understanding of adverse events and medicine-related harms, including hospitalisation. They're about a better knowledge base to understand medicine utilisation, to validate the intended clinical benefit. I mean, really, they're being used largely to ensure financial sustainability of the PBS. And that's the main driver here.
Let me put an alternative question to you. Senator, you're the one who just asked me inter alia, earlier on, whether I should really be paying any more than New Zealand for some of the products that we list.
I don't think I asked that
Well,
question.
that was kind of my interpretation. If I misunderstood, I apologise.
No, I didn't ask that question. I actually disputed the way you presented the various choices.
Righto.
In fact, I was probably being devil's advocate on that occasion.
Okay,
but anyway.
well, noting you've been devil's advocate, let me return the favour. And my question to you is, why should I, on the PBS, pay any more for a product which people will list for an outcome than I should, particularly when I have existing therapy on that schedule that for many people will be appropriate first-line therapy. And that is essentially the question that the PBAC has always asked.
Yes, and it asked that question, got an answer, and the review was done.
Yeah, but that's where it has always been open to government to ask a question.
Another question. I don't like the answer from the PBS.
But they don't keep doing it. And I think that's the important point. So, I mean, you and I can have a dispute about whether it's major or it's minor, whether it's long-term, it's short-term. I would, and as I said, I've been doing this since 1988 for my sins. My view is this is an evolution, it's appropriate, it doesn't stop the process, and as I've just said to Senator Fierravanti-Wells, the process now is continuing as it ever has. But those questions, I think, are completely financially responsible to ask that question about what is really appropriate. And your point, you made the point about antibiotics, fair question. And if the answer is we can't change any of the clinical behaviours, completely fair question. Completely fair question. But in this case, that's not what the answer was for us.
Yes, and look, I don't want this to become a circular argument, so perhaps I'll move on. I'll just...
I think where you've gone
Yes.
is 0.2.2.
Sorry, I've lost track
And
of
but that's fine. I mean, it was a natural flow of the discussion and the questions
Yes.
that came out of it. We need to take a break because I think that these questions are going on.
Okay,
So
yes.
I would like to complete 2.1, if either of you do have
Just
any
remind me,
further que-
2.1
which
is-
is community pharmacy
Oh,
and
yes, okay,
pharmaceutical
yes,
awareness.
yes, okay.
If there's either of you that have questions on 2.1, I'd like to complete that.
Mine were in 2.2, this
Right,
one, 'cause
that's
I
right,
think
because
this is
it
straight
flowed
into
on.
2.2.
Have you completed 2.1, Senator?
Yes,
So
I've got some questions about the audit of the community pharmacy agreement. I'm not sure if
Is
it's...
that would be 2.1, I would think.
Yes.
Of
would
the
it not?
community fund, that's 2.1.
Yes, so we're
Do
rounding-
those-
we're
do
rounding-
those?
Oh, just a general update on the audit.
The Australian National Audit Office audit.
Yes,
Yes, it was announced on their website 2 weeks ago, and it's
Yes.
expected to be completed in winter 2014.
okay, and the process?
That's a matter you'd have to
Okay,
raise with the
yes, yeah,
ANAO.
fair
Sorry,
enough.
Senator.
Yep, okay.
That's it on community
fine,
pharmacy? Okay, so we'll take a 15-minute break and come back to complete questions on 2.2 and then flow through for the rest of the...